A middle-aged man presented to you with the complaints of diplopia. He is telling you that he sees everything double and he does have diabetes which is uncontrolled. So as like always, we would first complete the introductory part and then straight go into asking questions about diplopia. When did it start? Did it start suddenly or gradually? Is there anything improving it or making it worse? Do you have any pain over your eyes? Do you have any other type of vision problem? For example, any visual blurriness, any color vision loss? Do you bump on objects? Did you fall down due to your vision problem? Is there any specific direction where the vision appears to be double vision? Do you have any associated headache or loss of consciousness? If patient tells you about headache, then exclude the raised intracranial pressure by asking him about morning headache and vomiting. Also in the clinical prompt it was written that the patient has diabetes, so ask him about diabetes, for how long he has been diagnosed as diabetic patient, what medications he take to control diabetes, and is he on insulin, and ask him about diabetes control status. Ask him about relevant family history, past medical history, past surgical history, and history of any other significant comorbidities. Many of the long-term uncontrolled diabetic patients may have kidney problems and peripheral neuropathy. So keep these two things in your head. Then move on to performing some focused clinical examination. Please be mindful that you would not get enough time to perform full cranial nerve examination, so do only the relevant examination. Observe for unilateral ptosis that commonly happens in oculomotor nerve palsy, and the features are dilated pupil and pupil is deviated to laterally and downwards. This happens due to lateral rectus and superior oblique muscle palsy. Then observe for the features of diabetes, for example, finger prick for glucose testing, any weight loss or weight gain, any obvious edema over his feet may suggest renal problem. Then formally examine the eye movements for cranial nerve 4 and 6. And if you suspect a surgical third nerve palsy, then perform a fundoscopy to observe for signs of raised intracranial pressure. Most of the times you would not have to perform it, so it would be a good idea if you ask the examiners that you would like to check for papilledema. The difference between medical and surgical third nerve palsy is a medical third nerve palsy will usually be pupil sparing and surgical third nerve palsy will not be. After completing focused examination, move forward to ask for some social history and other relevant histories covered in the earlier podcasts. I would not repeat the same things over and over again. Tell the patient about your suspected clinical diagnosis and further management plan in short. If it is a case of third nerve palsy due to diabetes mellitus, then tell him that I think one of your nerves in your eyes has got damaged due to uncontrolled diabetes. So diabetes control would be a key. I would refer you to our diabetes clinic for further information. Always ask for patient's concern and address these concerns appropriately. The examiners may ask you what are the causes of surgical third nerve palsy and medical third nerve palsy. The causes of surgical third nerve palsy are aneurysm or bleed from the posterior communicating artery, post-neurosurgery, post-trauma, and congenital cause. The causes of medical third nerve palsy are diabetes mellitus, infection, demyelinating disease, autoimmune disease, and cavernous sinus thrombosis. Examiners can also ask you about Horner's syndrome. Horner's syndrome is a rare condition that affects the nerves that control certain muscles of the face and eye. It is characterized by a set of symptoms that can include ptosis, constricted pupil or miosis, and decreased sweating, which is also called anhidrosis.